Good afternoon, everyone, and welcome. My name is Ken DeSergio. I'm a program director for Children and Family Futures located in Lake Forest, California, and welcome to today's webinar, Practical Issues in the Implementation of the Matrix Model. This is our fourth in a series of webinars addressing the implementation of selected evidence-based practices being implemented by grantees in the Regional Partnership Grant Program. Regional Partnership Grants are a program of the Children's Bureau in the Administration on Children, Youth, and Families, the Office of Child Abuse and Neglect. I want to welcome the Regional Partnership grantees and to all of our other participants who are not Regional Partnership grantees but are joining today's webinar and who are interested in today's topic. Our previous webinars have included Seeking Safety, Nurturing Parent Programs, Trauma-Informed Organizations, and Trauma-Focused Cognitive Behavioral Therapy. Children and Family Futures also offers a series of webinars through the National Center on Substance Abuse and Child Welfare and our Family Drug Court Learning Academy, which is supported by the Office of Juvenile Justice and Delinquency Prevention. And you can find those webinars on the Children and Family Futures website, and you'll see that later at the end of the presentation, as Mariana indicated. Now I'd like to introduce Elaine Stett, Child Welfare Program Specialist in the Office of Child Abuse and Neglect at the Children's Bureau, and the Federal Project Officer for the Regional Partnership Grant Program. Elaine?
Hi, Ken. Can you hear me?
We can hear you well. Good morning. Good afternoon, I mean.
It could be both. So good morning. Good morning, good afternoon to everyone. Thank you for taking the time to join us for this important webinar on practical issues in implementation of the matrix model. I know that from our ongoing work with supporting grantees along with states, courts, and tribes through the National Center that we continue to hear questions around the use of the matrix model, and we're always interested in hearing from you all as well. So I would just say thank you in advance to our presenters. Thank you to everyone on the phone for your time today, and I really encourage you all to use the chat function that's available on the side of the window for GoToWebinar. And as Ken said, there is just a rich number of resources that are available on the National Center website and lessons learned that we have cataloged over time and continue to learn with all of your support. So please join me in welcoming our presenters, and I'll turn it back over to Ken. Thank you.
Thanks, Elaine. Appreciate you joining us. Today's webinar, as Elaine mentioned, is brought to you by the National Center on Substance Abuse and Child Welfare. The National Center has been operating since 2002, and the National Center has supported the program of the Substance Abuse and Mental Health Services Administration and the Center for Substance Abuse Treatment and the Administration on Children, Youth, and Families in the Children's Bureau in the Office of Child Abuse and Neglect. We've appreciated the support of SAMHSA and the Children's Bureau in the years that Children and Family Futures has been operating the National Center. The agenda, I'd like to just cover briefly the agenda for today's webinar. In the short time we're spending together, today's webinar is not intended to train participants to deliver the matrix model. The webinar will provide a detailed overview of the key implementation issues to be addressed in implementing the matrix model and measuring the fidelity and outcomes of the model, drawing on the practical experiences of the developers of the matrix model. So it's my pleasure to introduce today's presenters. Our lead presenter is Jean L. Obert, founder and past executive director and present chairperson of the Board of Matrix Institute, a nonprofit corporation that delivers outpatient treatment and mental health services in the Los Angeles, California area. The Matrix Institute is affiliated with the UCLA Integrated Substance Abuse Programs and is a site for the National Institute on Drug Abuse Clinical Trials Network. Jean is one of the developers of the Matrix model of intensive outpatient treatment and the Matrix model for teens and young adults. Recently, she worked with others to create the soon-to-be-released second edition of the Hazelden Matrix materials and a Matrix manual for persons involved in the criminal justice system. Jean is also a motivational interviewing trainer, trained by Bill Miller and Steve Rolnick. She's been an active member of the Motivational Interviewing Network of Trainers ever since, and served as an expert trainer on a motivational enhancement study led by Yale University as part of the NIDA Community Clinical Trials Network. Joining Jean today with today's presentation is Andrea Weiner. Andrea is also at the Matrix Institute and currently the Director of Training and the Clinical Supervisor of Matrix Institute of Addictions. She has worked in many different capacities at the Matrix Institute since 1992. Andrea has been lecturing, training, and educating domestically and internationally in the Matrix model for over 20 years and has been trained as well by Bill Miller in motivational interviewing. Andrea is also an instructor in the Alcohol and Drug Studies program at UCLA, where she teaches on co-occurring disorders for addictions professionals. And with that, I'd like to turn it over to Jean. Good afternoon, Jean, and welcome.
Well, thank you, Ken. I want to thank both you and Mariana for helping us set this up. And I'm absolutely delighted to be talking to those of you who have been using the Matrix model and finding it helpful in your work, and also those of you who are just finding out about it. We have, both Andrea and I have spent a lot of years working with patients, and I'm hoping that some of our experience will be helpful to you today. Please feel free to ask questions as we go along, because we really welcome that. So just to get started, when we developed the Matrix model originally, we developed it on the basis of material that was out there that was already working. And shortly, not too long ago, the second edition of a little booklet called The Principles of Drug Addiction Treatment was published by NIDA, and that's available to people still. In that book, what they did was look at all the effective treatments, the ones that we had looked at when we developed Matrix, and at the Matrix model, and at cognitive behavioral therapy, all these different therapies. And they pulled out of those therapies what, in fact, were the most important components of effective evidence-based treatments. So what they listed in their little booklet are that there be multiple sessions for at least 120 days. And I don't think all of the managed care companies really abide by the 120 days. But we try to educate people as often as we can, payers as often as we can, about the need for people to be in treatment for 4 months if it's at all possible. They also said that it's important for people to come in for a minimum of 3 visits a week, and we've found that to be true too. And that's why, if you are familiar with the Matrix model, you know that it's set up so that people come in Monday, Wednesday, and Friday, although sometimes there are space issues, and so you may have to go to Tuesday, Wednesday, Friday, and then another track of patients on Monday, Wednesday, Thursday. However you do it, it's important to not have those 3 days be Monday, Tuesday, Wednesday. To actually spread them out over the week so that people who are struggling to stay drug-free have contact with your treatment center as frequently as possible, with as few days in between visits as possible. So that's an important part of how the treatment is set up. I'm a family therapist, and so is Andrea, and so are a lot of the people that we have working at Matrix. So it was important to us from the beginning to make sure that we had family involvement to whatever degree we could make that happen. And that's why the Matrix model is set up so that in the middle of the week, usually on Wednesdays, there is a component of the program that includes family members. Now, not everybody has family members that can come to that, and that's fine. people certainly can come to the education groups by themselves, but if it's at all possible to involve family members, we know now from the research that treatment is much more effective if you can involve family members. And certainly if you're doing adolescent treatment and you're working with children, the family program is really critical. Not that children necessarily come to the family education group, but we'll talk a little bit more about that piece later. The 12-step program in the United States is very popular and very available to people. So when we developed the matrix model, decided we didn't want to do the body, mind, and spirit part, but to really involve people in the 12-step program because it is so well organized and helps so many people. And when somebody finishes the matrix program, they then have a continuous ongoing support program wherever they go. And it is available in other places in the world too, although there are some countries that don't have as much 12-step, as many programs as where we are here in the United States. So what we did when we designed the matrix program is we put specific sessions in to orient people to the 12-step program. We don't do step work in our program. Instead, what we try to do is have on-site 12-step meetings at our clinic locations so that people can access those 12-step meetings in a friendly kind of way. And we see our role with regard to the 12-step program as one of orienting people to it, making people comfortable with it, helping people understand the benefit of being involved in the 12-step programs. Now, that's not to say that we, and maybe some of you who are doing matrix and have been doing it for a while, don't get people coming in who see the matrix program as an alternative to the 12-step program. We actually kind of like that because we believe that there need to be as many doors into treatment as possible. And so if people view that as another door into treatment, we don't tell them you can't come into treatment unless you're doing the 12-step program. What we tell them is come into treatment, talk with other patients who are in treatment, see what you think about it, maybe give it a try since it's here on site. And we actually end up with a fair number of people who were seeing us as an alternative to the 12-step program in the beginning, going to meetings and staying involved once they finish matrix. There are programs still, places where Andrea and I go and do training. There are some outpatient programs that don't do testing, either urine testing or breath alcohol testing. They trust their patients to let them know when they're in trouble. And we believe that that's pretty naive when you're doing drug and alcohol treatment because it's really important to have some kind of concrete way for clients to be able to show us that they're not using drugs and alcohol. And as a matter of fact, people do find it useful often and request that they be tested even after the program ends. So we'll talk a little bit more about that later too. And medications. More and more we're seeing medications being used in the along with the psychosocial interventions. So if we look at the next slide, you can see that there are certain treatments that are mentioned in that principles book, and these are four of them. In the principles book, you will see CBT, cognitive behavioral therapy, mentioned. You will see contingency management mentioned, and you'll see motivational interviewing as having efficacy and in evidence base. You will also see the matrix model mentioned, and matrix is a little bit different than those first three because matrix really is made up of components of each of those first three. So when we created the matrix model, we didn't really create something brand new that had never been heard of before. What we did create was a way of putting some of those things together in an easy to manage kind of format that works for clients. The other thing that we wanted to do when we developed the matrix model was bring research findings that were known in the universities and in the research settings down to the level where our patients could really benefit from those. And so along with the cognitive behavioral contingency management and using the motivational interviewing style, we incorporated some of the research in very simple terms that clients can really understand. And we'll talk a little bit more about that in the future too. So I think, Mariana, we have the first poll.
Yes, we do. Thank you, Jean. We'd like to see if you could all just take a minute to answer this question for us. We know some of you answered it in the registration process as well. Our first polling question for today is, at what stage of implementation is your site related to the matrix model? The options are exploration, installation, initial implementation, full implementation, or I'm unsure. We're going to give you just a couple seconds to answer. We have about 40% of the attendees who are identifying as being in full implementation, and then 31% of attendees who are identifying as being in the exploration information gathering phase, with the rest distributed between installation at 5%, initial implementation at 10%, and unsure at 14% of participants.
Wonderful. All right, so we'll try to fill in the blanks for those of you who are at the exploration information gathering stage. And if you have questions that we're not answering as we go along, like I said before, please feel free to ask those questions. So let's talk about the treatment components of the matrix model now. So in terms of the things that make up the matrix model, there are individual sessions with clients as well as a couple of different kinds of groups. The early recovery groups are for people who are in the early stages of treatment. We'll talk about each of these kinds of groups in more detail in just a minute. The relapse prevention groups are the longer-term groups that are the core, really, of the group participation for people. We talked about the family education group, the 12-step meetings. Social support groups are for people who have finished their primary part of treatment. The relapse analysis is a component that is used as necessary. It's kind of a PRN component of the matrix model for people who have attained some sobriety and continuing to relapse, and drug testing. So these are the things that make up the matrix model per se. Now, we'd like to find out a little bit more about the people that you are actually working with. So Mariana has another poll.
Great, thank you, Jean. Our next question. Currently, what is the most frequently identified primary substance at intake at your agency or treatment center? And as you can see, our options are prescription pain medication, heroin, methamphetamine, alcohol, or other. And we're going to give you just a couple of seconds to reply, please. I can say now that the most frequent identified was methamphetamine at 42%. Alcohol at 23%, and then heroin at 19%.
That's very interesting. Thank you, Mariana.
You're welcome.
Fascinating. One of the things that I haven't said yet, and that as we talk about the comparison of the manuals now, I think it's important to say is that when we first started Matrix, we started it with the idea that we were going to develop a treatment for cocaine users that was specific to them, because, and I'm actually on, yeah, that's the slide, the comparison slide. The people using cocaine were being treated with treatments that were appropriate for alcohol users and people who were using opiates, and they weren't really working that well. And so part of our motivation for starting Matrix was to develop this treatment that was specifically for stimulant users. Shortly after we were working on developing our model, people from San Bernardino County here in California came to us and said, we have a lot of methamphetamine users, and do you think that this model will work as well with the methamphetamine users as it does with the cocaine users? And we said, we don't know, but we'll give it a try. And so we started a clinic out there in Rancho Cucamonga and saw primarily methamphetamine users and discovered, and we did some surveys about this, we discovered that the treatment worked just as well with the meth users as it did with the cocaine users, since both of those drugs are stimulants and they have a very similar way of acting in the brain. Not identical, but similar. And so it was after that discovery when the methamphetamine epidemic hit, and it looks like it's still going on according to the poll, not just in this country, by the way, but I'm going to Japan next month, and they want me to come over and talk about this model because they have lots of methamphetamine users there using. So we're not alone. But CSAT came to us and said, we want to help you publish the manual since it's working with meth users. And that resulted in the publication of the CSAT manual. They also said, once our demonstration grant is over, and that's what we use to look at this, once it's over, we will publish the manual and make it available to everybody. And 3 years later, that piece had not yet been prioritized at CSAT. And so Hazelden came to us and said, look, you're using the manual, you have just the manual that you've published yourselves. We would like to publish the Matrix manual. And we said, yeah, but it's going to be out there for free because CSAT is going to publish it soon. And they said, never mind, we'll do a different kind of version of it, and it will be a broader base. And so we said, okay. And after that, CSAT came out with their manual. So you can see why it ended up that we have two different versions of the manual. And the CSAT one was the one that was used in the study, and so it was really specific to stimulants. And if you use the CSAT manual, which is available by download off of the CSAT website, then you'll notice that all of the handouts and all of the information is very specific to stimulants because it came out of our large demonstration grants and study looking at the effectiveness of the Matrix model. So it is in the public domain, though, and the good thing about that is that if people want to make changes to it, which we've had other countries that wanted to translate it, and we have people who want to adapt it for other uses, as I think some of you have for the child welfare kinds of things that you've been using it for, you're free to make any kind of adaptation to that public domain one that you want to make. And then we hope, following it up with research, looking at how effective that is. And if you do that, we'd love to know about it. The Hazelden manual, on the other hand, is a little bit different. There are more individual and conjoint sessions in the Hazelden manual. so there are 10 individual/conjoint, meaning you see the individual person and the family, and or the family in those sessions. Hazelden does sell hard copies of the manual. They're not inexpensive. However, any program only needs to buy one copy of it, of the therapist manual, and can share that and can copy the patient manual. So it's set up so that you can do that, so that you buy one manual from Hazelden and then you take either the DVD or the hard copy, depending on which version of the Hazelden manual you get, because a new one's just coming out, and make patient workbooks yourself from those copies. So the patient materials can be duplicated and are, in fact, intended to be duplicated. We also broaden the language in the Hazelden one so that it doesn't just talk about stimulants. It talks about opiates and alcohol and prescription medication. So it's much broader in terms of specifically the people that it addresses. Not that patients don't do fine with the CSAT one too, but this is intentionally broader. When you buy the Hazelden manuals, you also get the 3 videos with the family education groups. You'll get to see Andrea in person delivering one of the lectures, Sam Minsky, who is one of our national trainers, doing another one, and I'm doing the family one. So those are 3 videos that are really the core of the Matrix manual. And if patients don't have the information that's on those core videos, then they don't understand why they're doing the interventions that they're doing in the groups. Those same core things you can get through CSAT by downloading the DVDs that they made. I don't think they're sending out hard copies anymore, but it always changes, so check on the CSAT site. But we made some DVDs with patients actually talking, and they're the same content as the 3 core videos from the family education groups in the Hazelden manuals. Those 3 core groups are really critical for patients to get. But the Hazelden manual is under copyright and it's not in the public domain, so you can't just take it and use it for whatever you want to use it for. Andrea, do you want to say anything?
I think that the other challenge might be between the 2 manuals is when your clients are coming into treatment and they don't identify as a stimulant user, they have a hard time making the translation in their head, especially when they're a little more oppositional to being there, or maybe in a stage of change where they're in contemplation and are challenged by the CSAT manual that mentions stimulants or cocaine or methamphetamine when perhaps they're someone addicted to alcohol or prescription medication. And many of the sites have reported to us over the years there has been some challenges around that when they choose the downloadable material as opposed to the Hazelden material.
Great. We're going to talk now a little bit about each of these components so that those of you who have not been delivering them know what they are, and those who have hopefully will maybe learn something new about them. This slide says individual sessions, but it really is individual conjoint or individual family sessions. That's what it means. There are more of these, as we said before, in the Hazelden manual than the CSAT. There aren't any specific family sessions in the CSAT manual, but in the Hazelden manual there are. We really felt that that was important to include, especially in some of those cultures where they're not working necessarily on just individualization and seeing people individually, but the families, it's really important to these cultures that the families be involved in treatment. I know I remember one time when I did an evaluation with a Chinese family, and 10 people showed up for the evaluation session. There were grandparents and aunts and everybody who was interested, and I think that's wonderful. And we wanted to make sure that the manuals could be used effectively in those kinds of cultures, both in this country and in others. And also in the teen manual, we're going to talk a little bit later about some specific manuals that have come out of our basic manual. The teen manual is one of them. Hazelden published a teen manual, an adolescent manual, a few years ago. And of course, the family parts of the teen manual are critically important. In fact, the family education groups are different in the teen manual. We have one set of education groups for parents, where there's a lot of parenting taught and those kinds of communication skills and so on, and another for the teens, for the adolescents. So they don't necessarily do the family education group together. They do the conjoint sessions together. And certainly, anytime that you have a family member paying for treatment, it's important to involve them in the treatment process. These sessions are good for that situation too. So jump in if you have anything, Andrea. Next, the early recovery groups. The next slide, please. The early recovery groups have kind of a history to them. They came out, we used to do a lot more individual sessions than we do now. Once we looked at our outcome data and looked at what was happening with treatment, we discovered that we didn't need to see everybody individually, and we of course thought that it would be much more effective if we worked with people individually, but we discovered that that wasn't true. So we used to have a Friday night group that we called a stabilization group, and patients would come in on Friday nights for this little group instead of an individual session. And that group grew into what we call the early recovery group. So the early recovery groups are for those people who are not as stable as other people in the program and who need to be seen more frequently and actually need to get some individualized attention. So we do this for the first month of treatment, assuming that most of the people who are going to be a little bit less stable are going to be people in the first month of treatment. And so these stabilization groups or early recovery groups now happen on Mondays and Fridays right before the relapse prevention groups. And these groups can be co-led by people who are further along in treatment and have something to offer. The relapse prevention groups, as we said earlier, are the main group in the recovery process. They last for as long as the person is in treatment, 2 to 4 months. They are co-led by patients who have graduated from the group and are doing something to actively maintain their recovery. We invite them to be co-leaders. The information in the topics from the relapse prevention groups is really important for everybody to have. The groups are organized in a way that because they're open groups and people come in at different stages during the treatment process, the core information that they need they will get within just a few groups. And when you're working with people in the child welfare system, it's important to include safety planning as part of the relapse planning process in these relapse prevention groups, as well as in the family education group. I think we already talked about most of the things in this slide. I think that in the family education groups, those 3 lectures are really critical. You get those 3 in whichever version of the manual that you're using. And then this family education group is where you can make adaptations to the lectures. So there are 16 family education groups. And if you have some safety kinds of issues that you want to include, seeking safety type topics, or you want to include something that is culturally specific to the group that you're working with, you're free to use some of these family education groups to do that, and to sort of pick and choose the ones, other than the 3 core ones, the ones that you think are most important to the people that you're working with. So the 12-step meetings, as we said before, aren't always available in all cultures, but we do include them, and we include them on site when we can, so that people can access those readily. And then there are the social support groups. The next slide, please. The social support groups are sort of our alumni groups. Once people finish treatment, they're eligible for the social support group. And in fact, that after the 12 family education sessions, they actually move into social support for the last 4 sessions. And those are delivered in lieu of the family education group for the next year in treatment. Usually people come and go in these groups. If they need support, they come in for the social support group. And it's not as tightly led as some of the other groups, and it doesn't have real specific topics like the other groups do. It's open for the people who are coming to talk about the issues that they do need to talk about that are important to them. And this is where people really form bonds with other people who have been through the program, so that they can do things outside of the treatment program and that support their recovery with other people who are drug and alcohol free. The relapse analysis, we talked about the relapse analysis a little bit before. This was developed when we had people who were relapsing. They'd been clean for 6 weeks and then they relapsed. And then they were clean for 6 more weeks and then they relapsed, or 2 months or 3 months, or whatever that time period was that they just couldn't get past. And a relapse continued to happen at that point. And we decided to develop this tool where you sit down and analyze, use the tool to analyze with the person what's going on with them and why these relapses are occurring. It's usually an individual session, and it's not for people who have not been able to stop using, but rather for people who have these fairly predictable or frequent relapses after long periods of sobriety. And then the drug testing part of the program is an important part of the program. It should be done on a regular basis. We prefer weekly. It's done for clinical reasons, and in some cases, if you've got an agency who's requiring urine testing and they have consequences for that urine testing, if you can work with them to do their own urine testing so that you can do the clinical testing and they do their mandatory testing, it works better. That's not always possible, and I know in Rancho Cucamonga we have a big active drug court program, which, by the way, if anybody ever wants to visit that, we welcome visitors to the drug court program, especially if you're doing training here at Matrix and want to add that on. But in our drug court program, the judge does look at the urine tests as part of sort of the picture, but the judge understands that urine testing in that sense is an aid to treatment, and that if somebody is having trouble What they need is increased treatment, not necessarily consequences, negative consequences. So that is the drug testing, and now I'll just say a couple of words about the adaptations of the matrix model, the manualized adaptations on the next slide. We adapted the matrix model for some of the Native American people that we were working with. We created a supplement that is not a separate freestanding manual but goes with our manual. We got input from Friendship House in San Francisco to do this. That manual is available from Matrix. Nobody publishes that except us, but we do sell that. And then the Spanish manual, Hazelden created a Spanish manual. CSAT created one some years ago, but it's not really as up to date as the Hazelden one. So on the Hazelden website, you can get a Spanish manual, and you can get the education piece, the videotapes in Spanish. Recently, we worked with CSAT to develop another supplement that is a women's supplement, and maybe the women's supplement would be really useful for some of you who are working with some of the populations with mothers as part of it. The women's supplement follows the early recovery groups, so people get the basic matrix skills first, and then they move into some of the issues that are specific for women only. We worked pretty hard on this manual with CSAT and tested it at a lot of different sites, and I think it's a really helpful supplement if it would be useful to any of you. Hazelden published a teen manual a few years ago. That's available on their website, and it's a complete manual. It's different from the adult manual. It has different handouts that were created to be more attractive to adolescents than the regular manuals. So I recommend that if you have an adolescent audience. And the medication-assisted, we have new manuals that are just being published from Hazelden, and those new manuals published from Hazelden include a medication-assisted treatment section that we didn't have in the manuals before. So before we go to the cultures that have used the matrix manual, Mariana, do you have some questions?
I do. We do have a couple of questions coming in from the registered participants. The first one, has anyone broadcast the matrix model as a telemedicine effort? And if so, where has this been done?
So actually, we just this last weekend had a strategic planning meeting, and that is on our agenda for the next year in our strategic plans. So no, not yet, other than outside agencies doing that, but not a telemedicine kind of full treatment intervention, but we do have that on the drawing board.
Great, thank you. And a couple more. Are there any key considerations for using matrix within the context of a residential treatment program? Many agencies around the country are implementing matrix as a, quote, standalone foundation for the substance abuse component of a larger, more comprehensive program.
Yes, so the matrix model itself, oh, I'm sorry, this is Andrea, hi. The matrix model itself has been adapted in many inpatient settings everywhere. It's not done necessarily to structural fidelity. So if you've been trained in the matrix model with regard to clinical and structural fidelity, you are going to have some obstacles regarding structural fidelity, taking an outpatient model and adapting it into an inpatient setting. However, with that said, much of the material, especially a lot of the early recovery material, works very well in a 28-day or more residential setting, and it allows the clients to build a foundation for their own recovery. And we have seen a lot of success with our model being implemented in inpatient organizations.
Great, thank you. Maybe one more question, and then we can move ahead. There was one question about effective strategies for engaging parents in matrix model treatment. You've talked a little bit about the groups that you use, but maybe specific strategies that you found helpful for engagement?
Okay, so maybe Andrea and I can both answer this. The way that I have, or one way that I have used in the past, because it's sometimes very difficult. Parents are very angry. Family members are angry. Family members have checked out. They consider it the patient's problem, not theirs, the client's problem, and they don't want to be involved. And so sometimes it works if you say to family members, look, I understand where you're coming from, and what I would like you to do is sort of take a wait-see kind of attitude. Give your family member the opportunity to learn what they need to learn, the tools that they need to learn to stay sober, because it's really hard to do that without knowing these tools. View this as a course in recovery, and after a certain period of time, whatever they're willing to say, after a month or 6 weeks, if your family member is doing well in treatment, will you then agree to participate in the family part of the program? And sometimes people are willing to say yes to that kind of an agreement when they're not ready to come in the door immediately.
I would also add that I think it's really important with this model that we make the distinction that our family education groups are not family therapy groups. They really are education as a way for all people to feel safe in the room. Sometimes family members feel like they're going to be blamed, or the clients are afraid the family members are going to air all their dirty laundry. So with the adult materials, that family education group really does lend itself to an education format as opposed to family therapy. With the adolescent manual and that particular model, we've set it out so that the parents are with each other as opposed to mixed with their kids, so that the issues that are going to come up that have to do with parenting, living with a child with an addiction can be talked about freely without the kids in the room, while the kids have their own separate education group on a different night. Also, one thing to add, when the parents come in for that parent group on that night, the kids do attend the clinic that night, but they are in a separate room doing separate activities so that you have them there together but separate.
Yeah, and I think, Mariana, one other thing that I think is important to say about this is we didn't really put anything in this presentation about the stages of recovery, but one of the really important things that came out of the development of the matrix model was the identification of really predictable stages in recovery, particularly with the stimulant users. And besides the withdrawal stage, which is the first couple of weeks, and the honeymoon, which is the first month or so, there's this stage that we call the wall, and it's really important for family members. It's one of the things that's explained in those lectures that we were talking about. It's really important that family members have that piece of information, that this stage is part of the recovery process, because when somebody starts into that wall phase, it really does look much like a relapse. It looks like people are sliding backwards. And in fact, if you don't get through that wall stage, which is long, it's 120 days, and that's a long stage. It's a little bit longer with methamphetamine users than with cocaine users. And if families don't know about that, they're going to not be able to be as supportive in the recovery process. So just educate, letting them know that there's education here that they need too, so that they can the recovery thing is predictable for family members.
Great, thank you. And I'd just like to note, we are running a bit behind. Would it be possible to perhaps jump to the implementation driver slides and
Sure.
then move over to the Fidelity? And of course, all the materials and the details are available on the website and in the PowerPoint. And if anybody has any questions specific to the other material, please follow up with us either via the question and answer log or via email, and we'll make sure to provide that information.
Okay, so let's go to the implementation piece, and I apologize for us being so wordy. We have so much to say about this. We could probably talk for days, but trainers and key supervisors. This is central to the implementation of the matrix model, and we developed a very specific implementation plan for the matrix model. The trainers are a little bit different than the key supervisors because they are really different people that, the people that are good trainers are not necessarily good key supervisors and vice versa. So there are two aspects to the implementation that are critically important besides the core training itself. And of course the core training is central too. But if we look at the next slide, I can talk a little bit more about the training slide, the matrix trainers. Matrix trainers are actually people who have done the matrix model personally. They have been a therapist delivering the matrix model and adapting it to various populations and situations. And this is true both here in the United States. We have limited trainers here. We have plenty of trainers to meet the demand, and we're spread out geographically all over the United States. But we have just half a dozen trainers or so here in the U.S. And we have a trainer in Spain, and we have a trainer in South Africa. And these are all people who are really experts at the matrix model and have extensive experience. So we don't train people to be trainers and then all they know is the training. We have trainers who have a depth of knowledge that is really useful. So if you look at the next slide, the key supervisors, those are our partners. Those are Matrix's partners in the sites where people have received matrix training. So if you come to Matrix to do a core training, following that core training is the opportunity for one or two people to stay and get a very small, much smaller training in how to be a key supervisor. The key supervisors are designed to be the clinical people who really support the staff. They're the change agents, if you will, in the organization. They're the ones who do the supervision, who in some cases hire the clinicians. They do the training for people. They're responsible for assuring that the model is being done to fidelity. And we really want to support those key supervisors. We're coming up with new plans and new ways in the next year to really support and be actively engaged with the key supervisors throughout the country. No program can be certified, and there's a certification with the matrix model without a key supervisor on site. So these people are the people who make sure that new staff coming in are trained in the matrix model. In our key supervisor training, Andrea or Sam, one of those two people, does that training, and they give the key supervisors the tools to do training at their site. They are not encouraged to go out and do training outside of Matrix. In fact, we ask them to not do that. But on their site, they're the person who prevents the turnover from getting in the way of the program ongoing. So let's look at the characteristics of an ideal key supervisor on the next slide. This is the person who really does have, is really savvy about the organization and the dynamics of the organization and also credible to the clinical staff. It's the person who has excellent communication skills, the person who is able to knows the matrix model well enough that they can say to a clinician, no, you know about this particular stage of recovery. Well, that's what you need to be thinking about when you're talking with this patient about this situation. You know about thought stopping, which is one of the interventions that we teach. This is a place with this particular client where you might want to review thought stopping even though it's not the topic for this particular session. So this is the person, the key supervisor is the person who really can step in and deliver the model as an expert at any particular time. So Mariana, do you want to do the next polling question?
Yes, why don't we do the next polling question, and if it's okay, Jean, we'll jump to the Fidelity portion.
Yes, that's great.
And the information again about the supervisors will be in the presentation. All right, so our next polling question, do you have someone supervising your matrix model clinical staff? Options: not currently implementing matrix, no active supervisor, supervisor who was not trained in the matrix model, or supervisor who was trained in the matrix model, and the final option, key supervisor who would have been trained by a matrix trainer. Okay, great. As the responses come into Eugene, the majority are not currently implementing the matrix model. That would be 46% of the people responding. Then 25% have a supervisor who was trained in the matrix model, and 17% have a key supervisor trained by the matrix trainer.
Okay, great. So that's really relevant to the certification process, and we'll just briefly let you know about the certification process. Andrea is going to talk about that.
So some sites, after they've been to a matrix core training or we've gone to their agency, and they've also chosen someone to be a key supervisor, they look to this model as a model that's going to create retention and specific outcomes that they're looking for within their agency, and are also wanting to be recognized as a certified matrix site. And a certified matrix site is a site that has been delivering the matrix model for over 6 months, that does have a key supervisor on site. There is a process of applying for certification in which we will come out to the agency and we will observe what happens in the agency. We will listen to a group, a relapse prevention group. Go ahead.
Just let me interrupt. I think we're confusing the slide person. We're all the way up on Fidelity monitoring certification. What Andrea is talking about is on that slide.
Right. One more slide, please, Jonathan. Great. Thank you.
Go ahead.
So if you want to become a matrix certified site, there is a process in order for that to happen. We will listen to an audio tape of an actual relapse prevention group that the key supervisor deemed is most representative of a matrix relapse prevention group. And then we're able to come out to the site to do a site visit, and then we meet as a committee and talk about all the things we've noticed, and hopefully are able to award you a certificate of 3 years of certification.
And you really learn about all of this in the core training. So the way to start this whole process is to come to one of the matrix trainings, which are all listed on our website. And you'll learn about the Fidelity monitoring instruments here. Andrea can just for briefly talk.
Part of what's a really valuable tool to the key supervisors is our Fidelity instruments. One is called the minute-by-minute instrument that really helps with the clinical fidelity for the frontline staff who are delivering the matrix model. We talk about style, we talk about content, we look at some of the MI philosophical points that are very important within this model, and this gives the supervisor a roadmap to follow and also gives the frontline staff some understanding of expectations from a clinical perspective. with regards to certification, we're looking at 10 of those items being met in order to be certified. We also have the same Fidelity instrument from a structural perspective. Jean mentioned earlier the importance of not doing treatment 3 consecutive days in a row, but spreading it out. We look at the fact that you're implementing your groups 3 times a week. We look at the staff you're using, the materials you use, if progress notes are being written, and so on and so forth. Do you have a good grasp of the matrix model and the brain model? All these things are part and parcel to our Fidelity instruments. And you do get trained in these instruments at a key supervisor training.
I believe these are the structural elements you were just referring to, Andrea?
Yes, the next 4 slides are copies of that form that we use, the worksheet that we use. This one is the structural elements. It's 2 pages long, and then there's the and those have to do with what Andrea was just talking about. And then there are the minute-by-minute elements where we listen to the tapes and evaluate the therapist on these minute-by-minutes. And the key supervisors can certainly use these within the clinic settings to make sure that their staff is meeting Fidelity when they're working in their groups.
We use them in supervision as well.
So, Mariana, would you like to jump to measuring the impact and outcomes, just that one slide, one or two slides of the research study?
If we could do the polling question and then maybe ask a couple of questions to you about Fidelity. We did receive a couple.
Perfect.
Great. So if you all could just respond to our next polling question, which is your agency currently using any of these Fidelity monitoring tools? And the options are yes or no. Perhaps you're using other Fidelity monitoring tools, or again, not currently implementing the matrix model. Okay, Jean, again, we have the majority, 46% of those who responded are not currently implementing the matrix model. Another 33% are not using Fidelity monitoring tools right now. 17% are using them, and 4% are using other tools.
Okay, great. That's good to know, and I'm really happy to see that with those kinds of numbers, those of you who have not been trained or are using the matrix model are interested in it and have stayed on for this entire webinar. That's good.
Great. And Jean, if we could ask a couple questions to you and Andrea about Fidelity.
Please do.
So one of the first questions that came in the registration was, how do you address Fidelity when you're implementing the matrix model in that individual or more individualized setting?
So I think that when we talk about Fidelity, we're actually talking about a very specific, like setting up a program that has all the same elements as the program did that got measured for effectiveness. But if you're going to do individual sessions and use the matrix materials, you could use the minute-by-minute Fidelity standards to look at whether or not the person is delivering treatment in the style that the matrix is intended to be delivered, and whether or not they understand all the concepts that a person needs to understand. But somehow you would have to work in those basic 3 videos, those core videos, for it to be very meaningful in a completely individualized kind of program. And I'm not sure how a program would do that, but you certainly could use the videos as an education piece.
Great, thank you. Another question that we know is often, or another issue I should say, that we know is often a challenge for agencies implementing evidence-based practices is staff turnover. And I was wondering if you could speak a bit about how your program addresses staff turnover with the implementation of the matrix model, and any suggestions you might have for other programs.
Yeah, absolutely. Andrea and I are like both going to talk at once. Well, what I was going to say is that this is where the key supervisors come in. And because when we developed an implementation plan for the matrix model, we knew that from all of the literature, when you start implementing evidence-based practices and you train people in it, staff turnover is the big problem because they leave and the whole thing leaves. And that's why the key supervisors are so important and why we specifically train the key supervisors to be able to train new staff in the matrix model and support them in doing that. So that was the way that we designed the program to address that potential pitfall with implementation.
And I would add that we strongly encourage sites to have more than one key supervisor when possible. So if you actually have a situation where it's the key supervisor leaving, you still have another key supervisor on site. So we have built in our matrix core trainings the opportunity when we go to an agency for them to send people to us for a free slot in a key supervisor training because we think they're that important to the agency's success.
Good point.
Great. Thank you both so much. And yes, we can move into the measuring the impact section now. Thank you.
Okay, well, this is simply the particular study, the large-scale study that was done with regard to looking at the effectiveness of the matrix model. It was a matrix model versus treatment as usual study that was done in 2004, and it was funded by CSAT. It was a huge study with 978 methamphetamine users as subjects in that study. It was a multi-site study, so we had clinics in Costa Mesa, San Diego, Hayward, Concord, San Mateo, Billings, and Honolulu, my favorite clinic to visit. And in all of those sites, there was one person delivering the matrix model program with one research assistant gathering data, and the rest of the people in that site were doing treatment as usual. And people, when they came in for treatment, were randomly assigned to their treatment as usual or to the matrix model. And then we looked at the outcomes, and what we found is that the people who were in the matrix programs, who were randomly assigned to the matrix programs in those sites, did better in terms of fewer positive urines and in terms of staying in treatment longer. And so there is a reference there to that article, I believe. Well, there's a reference on our website, on the Matrix Institute website, for that particular study. And then I put a reference to another. Did you send, Mariana, did you send people copies of that second article?
I don't believe we did, but if you send it to me, I can distribute it to all registered attendees.
Okay. I can actually send you both of those articles, the one that I just spoke about and the second one, which is the Matrix Model of Intensive Outpatient Treatment, a guideline developed by the Behavioral Health Recovery Management Project. It was written a while ago, but it's a really good explanation if you're not using the model yet of the Matrix program. So I'll send you 2 or maybe 3 articles you can distribute to people if you like.
Yes, we definitely have a couple of more questions. Thank you so much. And we know that there is so much information to go through that we really had to sprint through to allow time for questions from the participants. We appreciate it very much. And we appreciate your patience on the line. A couple of questions that are going to go back a little bit more towards implementation, Jean and Andrea. One of the questions that we received, does the matrix model work with an open group model? And if yes, what have you found are effective ways to bring new people into the group?
Well, the model was written as an open group model so that you always have different levels of recovery happening at different times. So in other words, you don't have all people in withdrawal, all people in the honeymoon, etc. So when you build your model and you set it up as an open model program so that there's never a waiting list. And you want to keep the groups. You really don't want the groups to get any more than maybe a caseload of 15 in a treatment track with a group.
8 to 12.
8 to 12 is probably the amount of people that will show up for each group, so that you can manage an hour-and-a-half group that way. We have found that by keeping it open-ended, people coming and going, you have a lot more interaction in regards to the groups and people's growth within the group, along with a Matrix co-leader who's a graduate from Matrix who's been part of the groups and is also a peer mentor within that open group setting.
The other thing is, because of our early recovery groups, everybody who comes in is in an early recovery group, and we sit down with them and schedule, and we work with them on what's going to happen every hour between the time they leave the clinic and come back to the clinic. And those are in the early recovery groups. And those early recovery groups are really what cement people into the treatment process, and where we work with like some of the issues that people would have in the first month of treatment.
Great. Thank you very much. Another question we have, and perhaps from our attendees who have been implementing the Matrix model. Someone commented, we have been implementing the Matrix model for some time now. What are some of the most recent or upcoming changes?
Okay, so I think we're very excited about a couple of things. One is, I don't know if you've been using the Hazelden DVDs, but I think that using the CSAT, and they're available on the CSAT website. You can download them. I think they're on YouTube too. But those DVDs where the concepts are taught and then the patients comment about them, many people find those helpful. So if you're not using those, I would recommend at least taking a look at them and seeing if you think that those would be helpful. We also have 2 new manuals coming out. We have a criminal justice manual coming out that is a standalone manual specifically for criminal justice populations that deals with criminogenic behaviors as well as the substance abuse behaviors. So it's a very specific manual that Hazelden is publishing now. I think it's just in the last month, really. And also, we redid the core manual. So the Hazelden core manual is brand new. It's up to date with stuff about technology in it that you see with patients, with medication-assisted treatment covered in it. There are special individual sessions for patients that may need medication-assisted treatment. So that manual, I think, is going to be great. So those are 3 of the things that are really important.
And I would add on the new revised adult Matrix model manual, it's aligned with the DSM, the new DSM.
Oh, and in addition to that, our training, if you choose to come to a Matrix training, and we hope you will, Andrea has reorganized the training so that starting in January, you just fly into LAX and go to a hotel right there by the airport and get the Matrix training. Stay for the Key Supervisor training if you want to, and I think it's going to be great doing it that way.
Yeah, and we've added a criminal justice manual training as well to the training. That's optional if anyone is moving towards that manual and has already had the core training.
So thank you for that question.
Great. And just to clarify, a question for both of you perhaps, is additional information about those trainings as well as perhaps the publication dates or availability of those manuals available at the Matrix Institute website?
Yeah, correct.
Okay, great.
Andrea's phone number and the second to last slide actually shows general information for the Matrix model. Maybe we can put that up. That has the Matrix Institute website as well as Andrea's name, phone number, and her email, her training email. as the Director of Training.
Great, thank you. That slide is visible now for everybody, and included in your handouts is the contact information for both the Matrix Institute and for Andrea specifically. Great. I think we have time for perhaps a couple more questions. I think it goes in line perhaps with what you're already talking about, and it may answer this question already, but some people were asking about continuing education, or for those people who have been implementing Matrix for a while, what additional training would you recommend for them?
Well, these specialized trainings that Andrea is talking about are brand new.
Great.
So the specialized trainings are going to be something that might be appropriate for somebody if they wanted to do an adolescent training or criminal justice training. If they have not been trained as a key supervisor, you can come to just the key supervisor training, and I think that would be really helpful. In addition to that, we do on-site training. So if you have an organization that has been doing the Matrix model for a while, and you would like to have us come do an on-site training with you, or if you want to consider certification, I highly recommend that, and you could contact Andrea about that, and we will come to you.
We have open enrollment trainings in Los Angeles every other month. That's open to anybody to participate. We will do a Matrix 2-day core training, and we also do key supervisor trainings in that open enrollment training, and our specialization trainings of right now the Criminal Justice Manual will be starting in January. And as Jean said, we will also go to your site to do any one of those trainings.
And all of that is on our website, yes, under training.
Okay, great, thank you.
Mm-hmm.
Now, is there anything else you'd like to share, Jean or Andrea, as we close up? We just want to thank everybody who's been on the line with us for being patient as we move through the large amount of information available about the Matrix model, and just assure everybody that the webinar will be available and recorded for you to go back to, and that the handouts include much more information about the process of the key supervisors, as well as, I believe, information about training therapists to be ready to implement the Matrix model. So, Jean, anything that you would like to add?
Well, only that if somebody thinks of a question that they didn't get to ask before, we're always open to being contacted, both Andrea and I, and we'd be happy to talk to anybody at any time. We just really appreciate everybody's interest, and we're very happy that this is useful to people.
Great, and I think as evidenced by some of the responses to our polling questions, many of you are exploring the Matrix model, and this provides a rough intro to the model. But as you heard, Jean and Andrea are open and, of course, willing to answer any of your follow-up questions. And if we at Children and Family Futures or the National Center for Substance Abuse and Child Welfare can be of any assistance, we would be available as well.
Yes, and I will send you those articles, so everybody will get those.
Great. And I'd just like to end by providing the contact information that is available on the slide now, as well as will be available in your handouts. Available for you are the National Center for Substance Abuse and Child Welfare website, which has a number of resources about working with families in the child welfare system who are affected by substance use. Any additional questions specific to the webinar, please feel free to contact me, Mariana Corona, and my email address is available for you there. And again, the resources and materials from this website will be, for this webinar, will be posted to our website, cfffutures.org, for all of you to be able to access.
Thank you so much, Mariana, for all your help throughout this process.
Thank you very much,
Jean and Andrea. We appreciate it.
Thank you.
Yeah, thank you too, Ken.
Thank you all for joining us today. Have a good afternoon.